Welcome to Breakthrough. Today we're going to be talking about ACL primary repair. We have with us in the studio Dr. Wiemi Douoguih from Washington, D.C., Dr. Bertrand Sonnery Cottet from Lyon, France, and Dr. Greg DiFelice from New York City. Gentlemen, thank you for joining us to discuss such an exciting topic.
Thanks for having us.
Greg, so let's start with you. So in the 1990s, ACL primary repair was essentially abandoned. Why was it abandoned, and what made you think to get back into it for your patients?
It's very apropos that we're here at Arthrex because talking with Reinhold in the past and going over this, one of the first products that Arthrex ever went to develop was a way to repair the ACL arthroscopically. The trouble was back in those years was that right around 80s, 90s, many papers came out showing that the 5-year results of open ACL repair deteriorated. And so the whole world kind of moved on. They just abandoned the idea of ACL repair. My first job out of fellowship, I was working in an area with lower socioeconomic group, and I saw quite a number of people with multi-ligament knee injuries. And at that time, the technology wasn't up to par for the PCL reconstructions. And what I found was when I reconstructed all the ligaments, the patients didn't do so well because they didn't have access to therapy. The recoveries are very difficult from those reconstructions. And so when I went into the knee and saw the PCL was avulsed off the bone, I started to try and repair it. And what I found was that the patients were doing better because the surgery was smaller, and the knee was as stable as if I had reconstructed it. That was right when the shoulder arthroscopy instrumentation was getting much, much better. And so the confluence of all of those variables led me to start repairing the ligaments in the knee.
So Wiemi, how long have you been performing primary repair, and how did you first implement it into your practice?
So I've been doing it for just under 4 years. I was actually compelled by the work of Dr. Gordon Mackay, who I first heard talking here at Arthrex. And then he came back and talked about it again the following year, and his patient population doubled, and he came back the next year, and he was talking about doing it on elite athletes, and I thought, this is really interesting. So I actually flew him into DC to have him show me the technique, and he showed me patient videos and testimonials. We spent a couple days in the lab going over his technique, and it really made a lot of sense biomechanically and conceptually, so I bit the bullet and decided to try to do it in some patients. I started out conservatively, working with people that were sort of moderate demand, really had them buy into the concept that this is something relatively new, but that if it fails, we're not burning a bridge, and that we could always go back and do a reconstruction.
So for both of you, the multi-ligament knee is what really got you into these, and it's made a difference in your practice, Wiemi.
Yeah, no question about it. In fact, I work at a level 1 trauma center, and so I saw a lot of cases where sometimes less is more. When you do a whole lot of surgery and you take grafts from multiple places in the body, first of all, you have a limited number of places you can take grafts from. If you could just repair this and begin an early rehab program, you might end up doing better.
So Bertrand, you have one of the busiest ACL practices in the world, doing about 700 ACL reconstructions a year.
I'm sorry, Chris. I just did 666 ACL last year.
666, I apologize.
In fact, you know, since 2008, 2009, we have published a lot of paper in my group that's focused on the biology and the histology of the ACL. This has resulted in a strategy that's aimed to preserve all the ACL stamp when we are doing an ACL reconstruction, using the Samba technique, which is a single anteromedial bundle biological augmentation, where we demonstrate very good clinical outcomes. We have a lot of discussion with Greg in terms of ACL repair, but because I'm a careful surgeon and because of the history of high failure rate, it took time for me to move forwards and to start to do the ACL repair. In fact, I wait his clinical result will not suggest an unacceptable high failure rate to start my first ACL repair.
So there seems to be a recurring theme here. Now, Greg, can you take us through your algorithm of deciding who gets a ACL primary repair versus a reconstruction?
You know, it's evolved over time. In the beginning, I started, and I would only do the repairs for the absolute perfect tears that were off the bone, because that coincided with the multi-ligament knees with the PCLs. And so I had a group of patients who had the perfect tear, and it was a smaller group, and I started very slowly. In fact, it took me 4 years to collect my first 11 patients. And what I found was more and more success, as you guys are finding, And now when I indicate my patients, I tell each patient that we're going to go in and we're going to have a look at the ligament. We have an idea based upon the MRI what we're going to do. In fact, we've published some research that classifies the ligament based upon where the ligament's torn. And we're going to go into the knee and have a look. If it's a nice proximal tear, then we can repair it without the need for any other graft. If the tissue is a little suspect, we might add an internal brace. If it doesn't look like the ligament can reach the wall, then I'll add a small graft to it, and that's an augmentation procedure. And then only as a last resort will I do a reconstruction of varying sorts, depending on the patient.
So do you consent your patients for both primary repair and ACL reconstruction going into the procedure?
Yes, every patient gets consented for repair versus augment versus recon, depending on what we find in the knee. And the patients are very comfortable with that. When they hear that we're going to repair it if we can, we'll augment it if we need to, and we'll only reconstruct it if we have to.
So Wiemi, you talked about having the multi-leg trauma patient and the elite athlete, but are there other patient populations that you think the ACL primary repair is appropriate?
I think this actually transcends all populations. And actually the patient population that probably is best suited for in some ways is that sort of moderate demand person who needs to go back to a day job, who recreationally plays occasional pivoting, cutting sports, maybe runs triathlons. Because what happens is, and I've seen it, is that some people, they've come in and they've had a reconstruction on the opposite side and now we're repairing this. And they get back so quickly and they say, Doc, this feels like I just had a knee scope. It doesn't feel anything like the ACL reconstruction I had 5 years ago. So I really think this is actually a great surgery for the everyday athlete, in addition to certain applications in the elite athlete.
No, that's a great point. So it's not just the professional or collegiate or high school athletes, it's those people involved, like delivery people, people working in a factory, I think what you've called in the past industrial athletes.
Absolutely, there's no question about it. And I think, we all have trepidation about dealing with the high-level athlete, whether we're doing a reconstruction or repair, just because there's a spotlight on them. If you're trying this for the first time, I think it's very reasonable to work on that sort of mid-level, recreational, level 2, level 3 type athlete.
So Bertrand, what percentage of your patients are amenable to an ACL primary repair?
I used to say to my fellow that we have at least 5 years scientific work to determine when, whom, and in which population we can safely propose the ACL repair. The consensus would be acute proximal femoral avulsion, but I know that Greg extends his indication. However, based on many thousands of ACL reconstruction, I'm totally agree with Wiemi. And what really surprised me is how the recovery is fantastic after ACL repair in terms of pain, range of motion, but also and mostly in terms of muscle wasting. I used to say that it appeared for me that the knee doesn't recognize the severity of the injury and react as is the same way as following just a medial meniscectomy. So it's really amazing because the improvement for the patient is something completely different that I never had observed with any ACL reconstruction.
So Wiemi, you've mentioned how you've done these in elite athletes. How has the repair changed their rehabilitation?
Well, it's interesting because we've moved from sort of the timeline-based return to play to a milestone-based return to play for my ACL reconstructions over the years. And no one's ever really ready with the reconstruction until probably 8, 9, 10 months, and if not longer. What I found with the ACL repairs is that I apply the same protocol, and these folks are ready at 3 and 4 months sometimes, and I have to sort of hold them back. I mean, I do want to see biologic healing of the tissue, and I want to respect that. I mean, the internal brace that I use is so strong that I think that's what's doing the work in the early phases of the rehabilitation, and I want to respect that and not create a situation where the internal brace is doing all the work, the tear recurs, and then when they get to 5 or 6 months, it falls apart. So I still follow a milestone-based protocol, but I really try to target about 6 months for return to play for most athletes. Now, that being said, I've had some people come in. I had a young girl who was 4 months away from this race, and she had scholarships, multiple schools to do track and field. She had torn her ACL playing soccer 4 months before she had to compete in this race, and all of her scholarships disappeared. And she said, look, the docs told me it's going to be 9 to 12 months before I go back to play after ACL reconstruction. That's just not going to work because I need to run this race. I said, well, I have a new procedure for you. It's new and we don't have data. I said, but the worst case scenario is it fails and we have to go back and do a reconstruction. And it's like doing it on a normal template in knee. So long story short, we ended up doing the repair on her. She competed in the race and did very well, and then got a scholarship, Division I scholarship, to compete in track and field. She's now 3.5 years out, still competing, stable knee. So, I mean, I think this is really changing the game in terms of how we think about treating it. But my rehab protocol, I still like to target about 6 months, ideally.
It's interesting. So, Bertrand, you performed this surgery on a recent Olympian. Would you mind sharing that story with us?
It's in fact my first ACL repair, and it's a fantastic story. She's a skier, world ranking number 2 or number 3 in slalom, and the story starts 4 years ago. Just before Sochi, the former Olympics, she had an ACL ruptures 3 months before the Olympics, and we treat her conservatively with brace and rehabilitation program, but unfortunately it failed, and I had to do a classic ACL reconstruction. And it took 8 months to be back at the same level. And she called me in the middle of September, where she was in Argentina for the training before the season. And she was devastated because she had ACL tears on the other side. And she told me, I will announce my retirement because there is no way to be able to participate to the Olympic Games. So I said, no, please come back to Lyon. I have some proposal to you. I called Greg and we have a strong discussion on her case. And then I perform ACL repair with ALL reconstruction. She was able to run after 1 month. She was back to ski at 3 months, and she participated to her first world racing at 4 months. She's now in South Korea for the Olympics, where she will carry the flag of her country, and she will participate for the race next week. And I cross my finger, but it's already a fantastic story.
Oh, yeah, it is. What a great story. Just the fact that she gets to compete.
It's really amazing. And believe me, I was very well aware by Greg, but I never expect what's happened. And the evolution was something completely amazing, completely amazing.
I told him he should stop doing ACL repair right now. One and done.
Yeah, that's great.
Get the Olympic gold.
I love the fact that you picked your very first patient as an Olympian.
Yeah, in fact, because of all the lectures I heard, I was aware with the ACL repair. And because of all the publication we have done on biology, I was considering that it was one of the possibilities that you can use as a guy with a big experience with ACL. But believe me, I never expect this fast recovery, and particularly, I still don't understand why the muscle consequence is so slow and so. I mean, you can neglect the consequence on the muscle after this kind of surgery compared to ACL reconstruction.
I think buried in that story is something that's very important to not glean over, or to graze over, is that you have a contralateral ACL injury in a patient that was previously reconstructed. And as we know from a number of studies, notably Tim Hewitt's work, that up to 30% of patients will have a new ACL injury after their initial ACL reconstruction, and that's not something that is something that you can just sort of blow off. I think that's something that's very real. It's a very real phenomenon. And I think one of the reasons that it happened is, like we talked about before, is you're taking that tendon out, the ligament out, you're replacing with a dead tendon, and all of a sudden you've sort of lost the roadmap, like a GPS. You take a wrong turn, and now you have to reestablish a new roadmap, and that takes time. And it may never even come back. I've looked at my patients now 5 and 6 years out from ACL reconstruction. They come back, they still have atrophy. Even though they're back to playing their sports and they feel stable, they're not the same. And if you really get in the weeds and ask them carefully, they say they don't feel the same after their ACL reconstruction. They're doing pretty well. Or you'll find that even though they feel good, that they're not achieving at the same level they were before. There was a recent study last year where they showed that only 26% of NFL defensive players were still in the league 3 years after their ACL reconstruction, and that was compared to match controls, where the match controls were still playing. So this is something that I think we really need to get a handle on as a society and as a governing body, that this is not something, the conventional ACL reconstruction is not something that's perfect. It's not the gold standard that we once thought it was.
Those are some great points, very good points. So maybe, Greg, you could describe the technique that you helped pioneer for the ACL primary repair.
Sure, I'd be happy to. One of the main things about my technique is it's really, if you close one eye and turn your head, it really looks like a rotator cuff repair. And the reason I came up with it was because I do a lot of shoulder surgery, and I was using the advancing arthroscopic instrumentation from Arthrex back in 2005, and the anchors were getting better, the suture passers were getting better, and then I went down on the knee and I said, you know, I had done the first 3 ACL repairs through drill holes and tied them down, and I said, why don't we just use the swivel lock? It's perfect. We get aperture fixation right at the wall, just like a rotator cuff. We can get each of the bundles up against there. So what I do is I place a Bonnell locking stitch of number 2 fiber wire using a scorpion into each of the bundles, and then through a low inferomedial portal, I'll put the anchors up into the bundle footprints. For patients who have marginal tissue quality, I'm a little more worried, I'll use the internal brace and anchor it down through the tibia, down onto the tibia. So my technique is a suture anchor-based primary ACL repair with or without internal brace.
Now, Wiemi, your technique is somewhat different. Can you explain it?
So actually what I do is I place a whip stitch using a locking suture, much like you would place in an Achilles tendon repair or a patellar tendon repair, and then I pass it through a small hole in the femoral footprint, about 3.5 millimeters in diameter, and I bring a button through that's part of the internal brace along with that, and then I tie my repair stitch down to the button. I also tension my internal brace first and fix it on the tibia. While I'm fixing my internal brace with the leg in full extension, I maintain tension on the repair so that I don't over-tension the internal brace. If you tension the internal brace and you don't tension the ligament, then when you go back and try to fix the ligament down by tying it to the button, it gets stuck. It's like a rubber band, and you're trying to push it back up, and the internal brace is blocking it. So I've had good results with that technique.
Wiemi, let's switch topics a little bit and talk about timing of tear. Does it have to be performed in the acute setting?
So it doesn't have to be performed in the acute setting. I have patients that are 6 months out that where it's been successful. The concern is if you look at the preclinical studies by Martha Murray, where she looked at 2 and 6 week repairs, and she found that the ones at 2 weeks with augmentation tended to do well, but those at 6 weeks started to fall off. I really make an effort to try to get it done within that 2 to 6 week window. But certainly if you have a partial tear, high-grade partial tear, and you have some of the ligaments still attached, it's just sitting there waiting for you to fix it. And that may be a year, 2 years, if it stays in that condition, that you're able to fix it.
So Greg, what are your thoughts on the topic?
We've just gone back and looked at all of the ACLs in the past, I think it was 8 years or so, and we divided them based upon when we got to them. And it was, the dividing line was 3 weeks, we saw a significant change. If we got to them before 3 weeks, it was 80% we were able to repair and 20% not. Now, mind you, my practice is a little skewed because a lot of people come to me for repair. But right after the 3 week line, and if you get out to the 6 week line, it drops down and you can only repair about 30 or 40% as you go further out. That being said, we're preparing a manuscript looking at 56 patients who we did from anywhere from 6 weeks all the way out to 11 years. And I know people shake their head and say 11 years, but it was very interesting. This patient came in with a locked bucket handle meniscus tear. And when I examined his knee, I said, you know, your ACL's out. He said, oh, I tore that 11 years ago, and I just stopped playing all sports. And he was about 36 at the time. And I said, well, look, we got to go in and fix the meniscus. I do this procedure called ACL repair. I can see on MRI that your ACL is sitting there. It kept its length. It's scarred to the PCL. We can pluck it off the PCL and reattach it, and you really have nothing to lose. If it doesn't work, you're right back where you were. And so we did that. The patient agreed, and he did great. We've reported on him and published a paper with 2-year follow-up. KTs are great. He's back to playing sports after all those years. And so I think there's a variety of time frames, and you just need to have an open mind as to what's possible.
So Wiemi, if a patient fails an ACL primary repair, does it affect a formal reconstruction later? For instance, do you burn any bridges, so to speak?
No, and actually that's exactly what I was going to say, is that you don't burn a bridge. When you're doing a reconstruction in a failed ACL repair, I've done over 100 and I've had 8 failures. And in each case, when I went back to do the reconstruction, it's as if you're doing it on a normal template. You don't have a big bone tunnel, you don't have a notchplasty that somebody did. You have the normal anatomy, you have the footprint to reference where you're going to do your ACL reconstruction. It actually is pretty easy, almost as like a virgin tear.
Now, Bertrand, you're a big proponent of the ALL. Do you ever perform the 2 surgeries together?
We published last year a 3-4 less graft rupture rate when you have a combined ACL and ALL reconstruction compared to any isolated ACL reconstruction. In my mind, when you have ACL tears, a majority of patients get also an injury of the anterolateral structures, 90% for ferrity. And we have a paper accepted in arthroscopy journal where we show on a 3D MRI that's 90% of the patients that get injury of the anterolateral side concomitant to the ACL. So for me, it's logic to address the ACL tears, but also to address the anterolateral injury by adding a ILL reconstruction or maybe a repair of these structures. But for me, we have to do something on the lateral side.
So Greg, what do you tell the skeptics who are apprehensive about performing an ACL primary repair?
I tell people, start slow, like all of us do. You're nervous, we care about our patients, we don't want to see them come back if they have a re-rupture. So you start with the perfect tear. You start with the one where you look into the knee and you say, oh, look, it's not torn. And then you take the probe and you go, oh, look at that, it's off the bone. And you can learn the techniques, they're online. You can come down to Arthrex, practice on the cadavers, read some of the papers out there, and realize that what we're doing is not that complicated. It's not that risky. It changes really the risk-benefit ratio of ACL surgery in the favor of trying to repair it rather than do the recon. So I tell people to start with the easier tears, and then as you get more and more experience, and you'll be impressed by how quickly they recover, then you'll start gathering steam and being able to address some of the more complicated tears.
So gentlemen, any final thoughts? Let's start with you, Wiemi.
Yeah, and this is an exciting topic, and I really don't think it's going anywhere. I think the future of treatment of ACL injury is going to involve preservation. The more we do this, the more we find out. Greg's been doing it for 10 years. 5 years from now, it's going to be 15. We'll all have more experience in doing it. And it sounds like there's surgeons around the country that are starting to adopt this. We're going to have a lot more information to be able to arm us with proper treatment, better treatment than we have right now. I think holding on to sort of old norms is not going to do us any justice. I think we need to sort of throw out some of the stuff that's dead wood, keep some of the things that have worked in the past, and incorporate some of the new things that we're talking about today. But it's a very exciting time.
Bertrand?
My conclusion is that we must continue slowly based on scientific evidence like Greg has done. And we need comparative study that you start, which is very important in terms of scientific evidence. But my preliminary clinical results show so amazing improvement for the patient that, believe me, for the next few years in my group, the ACL repair would be definitively an important subject of research.
Greg?
Well, I think it's very, very gratifying. All those years ago when I started pulling on that little string and I followed the hunch that this was going to work, I really deep down inside felt that this had the potential to change the way knee surgery was done in the whole world. And it's taken some time, and that's okay. It takes time for people to come on board. And now we're having an academic discussion, and we're pushing the ball forward to the benefit of our patients worldwide. I think we're talking about isolated proximal ACL tears, which is a portion of the what I call the low-hanging fruit on the ACL tree. But there's also a couple of other places where this is really applicable, especially the partial tears, especially in kids, where the knee's a little loose and the ACL looks a little torn and you don't know what to do. Well, now you have a tool in your toolbox that you can do a diagnostic arthroscopy, take a close look at the ligament, and potentially tighten it back up if need be with a very minimally morbid surgery.
Well, gentlemen, thank you once again for joining us today. I think this has been a really interesting episode.
Thank you.
For more information about the ACL primary repair, please contact your local Arthrex representative. You can also visit and register at arthrex.com to learn more about how the ACL primary repair can be used to help you treat your patients better.